All right, good afternoon, everyone. Before I introduce our speaker for today's work in progress session, I wanted to acknowledge that on Friday, it is International Employee Appreciation Day, which we're celebrating today. Wednesdays seem to be the day that we're often in the building, so that's what the cupcakes are for. So just wanted to express all the gratitude that we have, I have to all of our Regenstrief employees today and every day. Thank you so much for all that you do. I know that in the this year, this feels like it's been a long year already, and it's just early March. But we have definitely experienced a lot of challenges, and I've seen our teams really come together in responding to those challenges. I know that people are working really hard, and there's some teams that are working extra hard, and there's a lot that's being demanded on our time right now in a sort of changing environment and some uncertainty. And so I just really wanted to acknowledge the work that you all do every day and all of your contributions to the Regenstrief Institute. You make an impact, and we really appreciate you. So I also know, I think many of you saw the email I sent out on Friday that it feels like not great timing to be sort of saying we're celebrating our employee and staff, but also saying that the email I sent out on Friday that we're delaying the decision about funding increases. We're waiting for a few different pieces of news on the federal front. I think we'll know more hopefully in the next couple of weeks with the budget hopefully being passed and on the federal government. But we are looking for more, and we will continue to evaluate that information. And so either way, regardless of that news, we really wanted to still take a moment to just say thank you and celebrate. So enjoy your cupcake. And a round of applause for all of our amazing staff. Okay, so now I'm going to turn over to introduce our speaker for today. So Dr. Titus Schleyer leads, he is a Regenstrief investigator within the Center for Biomedical Informatics program. He is a leader in a number of different areas. He is has a DMD, so he has a dental background and also a PhD degree. And his work has focused on a number of different areas, but he's been really interested in this topic of sustainability of late. And recently launched a study on the effects of change in air quality in Indiana on multiple medical conditions recently. There's a whole lot more about Titus that he told me just go ahead and move on so he has time to present the WIP. So I'm going to hand it over to Titus now, and thank you for presenting today and hope for some engaging conversation. So this should be interactive. So look forward to think about questions that you can ask Titus. Thank you.
Thank you, Rachel. Appreciate it. So welcome to another mystery talk in the series Work in Progress. The question I want to discuss today is sustainability in healthcare. Why should we care? So for many people, sustainability, environment, climate change feels kind of remote, Polar bears floating away on their icebergs, rising sea levels. It all kind of feels not connected to healthcare, where we are, in fact, trying to make and keep people healthy. And my one and only purpose today is to actually help you make the connection between healthcare and sustainability and show you that it's actually inescapable to have that connection. Let me introduce you visually to some of my colleagues. What you're going to hear today isn't just what I did. These are some of my co-presenters at this workshop that we gave at AMIA last year, AMIA Fall Symposium about healthcare sustainability. Several of those people are also leaders in our new American Medical Informatics Association Climate, Health, and Informatics Working Group. So you'll actually get lots of information about what they did. And of course, there's 100 members in the new working group that's about 2 years old. So there's actually quite a bit of a force behind this. So the story I want to tell you today starts with the statement that healthcare is philosophically compelled to operate sustainably. We'll talk about pollution and environmental degradation caused by healthcare, as well as, or how these things affect health, as well as healthcare's contribution to that. In the middle, I want to kind of tell you a little bit about how you can engage with efforts to improve the situation, and then we'll wrap up with current projects and opportunities for the Institute itself. So this slide I stole from Bob Biggio, who is the head of sustainability at Boston Medical Center. And most people kind of think sustainability is not healthcare, but that's actually incorrect. So if you go back in history a little bit, there's this kind of one thing that a lot of people with medical training either hear or memorize, and that's this statement. So number one, what does it mean? Do no harm, okay? So Latin for do no harm. So 100 points for this. The second, maybe a little bit more difficult question is who said it? From the Belmont Report. Could be a good guess. It's a little bit older than that. Think of Principles for Physicians. Okay, you fell right into the trap. It was a trap. Okay, I actually thought Hippocrates said this too. Okay, he didn't speak Latin at the time, at least. So no, it actually most likely goes back to an English physician, Thomas Sydenham, in the 1600s. But it's a pretty old statement. So do no harm, we're not supposed to harm people or patients. And you're starting to see kind of where I'm going with this. First of all, of course, we're supposed to do good for the patient population who comes into the doors of our partner healthcare systems. But beyond that, we're not supposed to damage populations. And this is where healthcare and greenhouse gas emissions comes in. So here's a little set of numbers on greenhouse gas emissions. First, at the top for the healthcare sector. So in the US, the healthcare sector emits about 8.5% of the greenhouse gas emissions. Worldwide, it's about half that. The US contribution to worldwide emissions is about 25%. That number probably rings familiar because that's about the number that the US contributes overall to worldwide GHG emissions. And then for context, I've put in some other sectors. So electricity and heat production is pretty big, 34%. Computing is only 2 to 4%, but we'll come back to that topic. And aviation, everybody thinks getting on an airplane is really, really bad, which is true. Individually, we have a big footprint when we take an airplane ride, but overall, it's really not as big of an issue as people always think it is. So think of these numbers as we go through the talk and look at some of the facets of this. A key paper that I would like you to take a look at, and it's an editorial, so it's fairly short, is one that was published in 2021, and it was a call to the healthcare community worldwide, kind of a wake-up call about emissions and the global rise in temperature. So many of you have heard about the 1.5% threshold for global warming, and that crossing that threshold will have increasingly negative consequences. There are indications that we're already at that threshold. So now people are talking about 2 degrees. Climate change is the greatest public health threat in the 21st century. And just by way of importance, this editorial was simultaneously published by 200 major medical journals worldwide. So what about the connection between health and climate change? So the CDC had this nice picture up on its website. I say had because I haven't checked today, but it's most likely gone now. You see some URLs in this talk. I didn't religiously check all of them, but a lot of material about climate change has vanished from United States federal websites. So let's unroll that graph a little bit. So in the center, you see kind of the motor for all of this, the increase in CO2 levels that causes rising temperatures, AKA global warming. That results in more extreme weather, and we also have rising sea levels to go with that. In the middle circle, you see kind of the more proximal consequences of that. So you see extreme heat, which we have witnessed here, severe weather, same thing, and other things. And then on the outer periphery are the health impacts. So Rachel mentioned when she introduced me, we are doing a study on air quality and respiratory disease. I'll tell you a little bit more about that in a little while. But many of you will remember the Canadian wildfire cloud of 2023. I was probably the only person crazy enough to ride my bicycle during the days of this wildfire cloud. But I definitely could sense and experience decreased air quality. So we have weather-related things that happen. If you look at the extreme heat sector, we've all read about people getting heat stroke, people who work outside in construction, farming, and so on. But it also hits people in the city who don't have good access to air conditioning. And the health consequences of increased temperature, both chronically as well as kind of during these heat waves, can be significant. Drugs don't work as well or differently when you're dehydrated. People have trouble keeping their glucose level. Diabetics have trouble keeping their glucose level stable. So there's lots of things that can happen. Also want to direct your attention to mental health. So mental health is an interesting sequela of climate change because one, you can be very depressed once your house burns down, let's say in Los Angeles. But you can also be very depressed just by the virtue of the long-term effects and somewhat ominous and for you not controllable consequences of climate change. And maybe a last item or last sector to briefly mention is vector-borne infectious disease. I'll tell you about another project that we're doing in this area, but that even happens here. You might not sense it or you might not experience it, but for instance, in Germany, we now have West Nile virus as an endemic disease. Why? Because the mosquitoes that carry West Nile virus can now survive in the warmer temperatures that are definitely not what they were when I was a kid. I remember fondly lots of snow, cold winters, but that's actually the exception these days. So mosquitoes that carry the West Nile virus survive until early spring when they get active again and of course need to attack humanity in Germany. So here we'll talk a little bit about the healthcare and its emissions. You might notice something strange about this picture. Any guesses? How did I make this picture? AI, okay. It's the only AI picture I use in this talk, I think. Why? Because creating an AI picture actually has a big carbon footprint, okay? I don't know whether you guys knew this, but AI algorithm is both very energy intensive when you make the algorithm, when you train it, as well as when you run it. So think about the next time you search on Google, okay? Google by default now shows an AI search result at the top. That result is about 10 times more expensive computationally than the rest of the results. This picture is actually 100 times more computationally intensive than, well, you can't generate a picture with a Google search. but compared with a Google search, this actually takes a lot of energy. And this leads directly to the fact that major tech companies have now rolled back a lot of their climate pledges to, for instance, be carbon neutral by 2030. A lot of this is going out the window because of the growth in AI. So what are emissions like in healthcare? So we divide emissions in healthcare, just like in other industries, into three components or three scopes. The first one is emissions that happen directly from the facility or from the organization or from the industry itself. So that's scope one. The second one is purchased electricity. So somebody else burns something to generate the electricity. And then scope three is what we call the supply chain, everything that makes the industry possible. And so here you see some examples. This is from the National Health Service, who actually worldwide is the healthcare system that's ahead by length of most other healthcare systems in becoming sustainable. So heating and cooling your building with fossil fuels, for instance, counts in scope one. Your anesthetics, which we'll talk about briefly, also your vehicles. Scope two is simple, purchase electricity. And then scope three has lots of different items in it. Your drugs, your waste, business travel, medical devices, and so on. So your next question is probably, well, what are these three scopes contributing to emissions? And so this is what this chart shows. So scope one and two are actually only 18%. So the emissions that are most under the control of a healthcare system only really are 1/5 of the overall emissions. So you see scope one is 7%, scope two, electricity is 11%, and then the rest is the industry that supports us. Pharmaceutical is big, medical devices, food, water, and waste. Another way of looking at this footprint, carbon footprint, is to say, well, what do our various activities consume in terms of, or generate in terms of greenhouse gases? And you see that hospital care is the biggest one. That's followed by physician and clinical service and so on, all the way until you get to dental services. So I was happy that, my professional degree or professional background was mentioned there. Dental services is 5% of the nation's healthcare expenditures, but it only contributes 3% of the greenhouse gas emissions. Some of this is nitrous oxide. I don't know whether you ever had laughing gas in a dental practice. Pretty efficient at calming patients, but also not a great gas to have in the atmosphere. So we use nitrous oxide, of course, in multiple places, not just in dentistry. And one thing that I learned a couple of months ago is the interesting fact that when we run pipes of nitrous oxide to the places where the gas gets delivered, 80% of the loss of the gas or the emissions is actually on the way there. Only 20% of the gas makes it to the actual setting where the gas gets used. So a lot of people are trying to move us to the cylinders that you can drive around away from these central distribution systems. Two concepts I also want you to kind of know about. One of them is called mitigation and the other one is adaptation. And these are central to how we look at responding to climate change and sustainability challenges. So mitigation is things that reduce greenhouse gases, gas emissions. So basically reducing your carbon footprint. And so we'll go through some examples in a little bit, but think about how we construct and maintain our building. We can insulate buildings very well, then we don't need to spend as much energy heating and cooling them. Adaptation, on the other hand, is adjusting to current and future effects of climate change. So basically it says, okay, what's going to happen is going to happen. How do we mitigate that? And I'm sure you can imagine that plenty of healthcare organizations have struggled with the concept of adaptation over the last 5-10 years, because it's really hard to keep your healthcare system operating when there is a major tornado washing over you. So in addition to the catastrophe that is wrought by these extreme weather events in particular areas, or Hurricane Helene last year was one example, you also have the challenge of your healthcare system breaking down if it's not sufficiently ruggedized. And then another example is supporting people and patients at risk from environmental harm. So what are we doing to help people not die in a heat wave? Okay, some of those are our patients, some of them are just people. But how do we exactly make that happen? And I'm sure you can, from your read of the popular press and other sources, you can enumerate some of those things, access to cooling centers. Some states here have passed laws about outdoor workers and making sure they don't keel over during heat waves. So that is adaptation. I'll give you two examples of some significant reductions in greenhouse gases. Move on to an interview with the Executive Director of Sustainability at IU Health. So this is an example from Stanford, and as you probably recognize from the years, this was the great natural experiment called COVID-19, okay? So nobody before, if you look at 2019, there was actually, you can't distinguish or discern that there were an appreciable number of video visits. Most patient visits were in person, some by phone, a small percentage. That changed in early 2020 when we isolated and we stopped most or many in-person visits. And so video and phone visits grew. And it kept going through 2021. The interesting figure here is, despite an increase of about 200,000 visits, bringing the visits to close to 2 million for Stanford University Medical Center, because of this use of telehealth, emissions dropped by 36%. So like more than a third. So think about that for a moment. A public health emergency forced us into doing business differently. And suddenly healthcare, in this case, Stanford University Medical Center, generates a third less emissions than it did before. Okay, I found that quite impressive. A second equally impressive example comes from Boston Medical Center. So I told you that I stole the first slide I showed from Bob Biggio, the Director of Sustainability for BMC. And he has an extremely impressive talk that chronicles BMC's trajectory from 2011 to 2022 in terms of their greenhouse gas emissions. And one of the major things that they used, major factors they used to achieve a 10-fold reduction in emissions. So 2011 is 100%. Now they are probably actually less than the 9% shown on this slide. So they managed to reduce their emissions by a factor of 10. And a lot of that had to do with the way they managed their buildings, managed electricity. And you could kind of probably see that when I showed the slide with the large portion of hospitals' contribution to greenhouse gas emissions. So Bob has an extremely compelling story to tell, and sustainability is part of the DNA of this organization. It's not just about buildings. They have solar farms on several of their building roofs. They manage waste in an extremely conscientious manner. They have roof gardens that help feed their patients. And they even give free electricity prescriptions to their low-income patients from energy that they generate. One of the people on our leadership team of the working group, Mani Berenji, she actually worked at BMC like a couple of years ago. And I asked her, this sounds so incredible. Like, what's the story here? And she just looked at me and she says, this is real. Like when you are there, you live, breathe, and act on sustainability. And on top of that, over the last 10 years, BMC has saved $500 million in operating expenses. So again, a very impressive record of sustainability. Here I've listed a few places for sustainability in healthcare. So these are some of the major efforts that you'll see, and it's not the only ones. There's actually probably tens, if not more than 100. Practice Green Health is notable in as much it works directly with healthcare organizations on sustainability. I was very happy to hear that IU Health is actually a member of Practice Green Health, and they have monthly meetings that I also most times attend to talk about how does IU Health advance in sustainability. Healthcare without harm is closely related. And of course, if you feel like it and are a member of FAMIA, or even if you're not a member of FAMIA, feel free to join our working group. So with that, let me switch to the interview with Mary.
Taking time to talk with me today.
Thank you for having me.
As you know, we are broadcasting this as part of a workshop at FAMIA. If you could briefly introduce yourself first, I'll ask you some questions after that.
Okay. My name is Mary Stotts. I am the Executive Director of Sustainability for IU Health. I've been here 5 weeks. Prior to coming here, I was at UW Health, which is the academic medical center for the University of Wisconsin-Madison. And there I was the director of facilities for the clinical arm of the organization, and I did a lot of work around energy efficiencies, fuel efficient vehicles, recycling, increasing our recycling, all under sort of the umbrella of saving money.
Very cool. So in general, can you tell us why you think healthcare institutions should invest in sustainability?
Yeah, I mean, I think environmental health is connected to the health of our population. So I think it's really important for healthcare to understand that connection between the health of the environment and the health of our populations.
Okay. And what is the incentive for UW Health, and maybe also, if you know, here, to start investing in sustainability?
I think originally for UW Health, it was to save money. And that was sort of where we started. And we saved a lot of money through different anesthesia gases that were a lower climate impact, but also saved money. We eliminated table paper from our exam tables. We reduced our waste. We increased our recycling, which was less expensive for us. So in the beginning, there was a financial incentive, and then it quickly sort of turned into the senior leaders recognizing that our staff want this, our doctors want this, our residents want this, all of our students want this, so we should be doing it, and the community wants it.
That's pretty cool. A lot of times people actually don't think of saving money as a first priority. But I'm happy you led off with that, because that's usually a big argument. Can you tell us a little bit about the concrete sustainability goals that you've either pursued at Madison or that you're pursuing here?
Well, by the time I left, because this is also becoming important to the Joint Commission, which is the accrediting organization for a lot of healthcare, it's becoming important to them. So I set goals for UW Health to reduce our greenhouse gas emissions, reduce our waste, increase our purchasing of sustainable materials, reduce our food greenhouse gas emissions. So I set a lot of goals, and that's important to get the Joint Commission Sustainable Healthcare Certification. So we were pursuing that when I left.
Very cool. What's been easy and what's been hard on that journey?
Well, I don't think anything has been easy. I think it's all hard because large systems, you need to engage people in this work. I'm only one person. I can't do this work without engaging employees. And sometimes engaging employees is very hard because they're taking care of our patients. We're taking care of patients. We're trying to have them get healthy and get out of the hospitals. So employee engagement has been hard, but once you sort of flip the switch and they see, wow, not only can my department save money, I can be more efficient in my work, then they start to see the benefits and they're on board.
Can you tell us a little bit about the tools and resources that you found useful on this journey?
Yeah, right away we joined Practice Green Health and Healthcare Without Harm when we started this journey, and I did that intentionally because they have resources and they have benchmark data. And the benchmark data is really important so you can see where your opportunities to improve are. And the peer-to-peer exchanges are also really valuable, learning from colleagues across the country what works for them, what hasn't worked, because everyone's at a different point in their journey too, so it does help to collaborate.
How does top leadership, either here or at Madison, how do they relate to those efforts?
So here, one of the things that really interested me about this position is the enthusiasm for the work. While I was interviewing, everyone was very enthusiastic about starting on this journey. And Dennis Murphy actually took the time to interview me for this role. And that spoke a lot to me about the importance that IU Health places on this role. So that's really what led me in this position.
Dennis Murphy, for the record, is the CEO of IU Health. And speaking of IU Health, so you talked a little bit about impact when you first talked. It's a statewide health system. How do you see that impact materializing?
Well, that's one of the things that also intrigued me about the position is I could have a greater impact. UW Health is a smaller system. We have 6 hospitals, 3 of which were under our control. The rest were JOAs, joint operating agreements, and I didn't have control over them or I couldn't influence them as easily. And that's what intrigued me about this position. It's a much bigger system, 16, 17 hospitals, a new one that we're building that's going to be LEED Gold certified. So that's what really intrigued me about this is the opportunity to have a greater impact.
Yeah, it's great to see that commitment. Last big question, what are the big trends that you see affecting healthcare and how it views sustainability?
I think climate mitigation is pretty much on everybody's radar, right? Looking at opportunities to reduce greenhouse gas emissions through energy, waste, anesthetic gases, and then just waste reduction in general. Hospitals produce about 5 million tons of waste a year. Now, about 30% of that is from our operating rooms, and obviously we need to keep patients safe. So there are a lot of supplies we need to use, but there's a lot of supplies we don't need to use. And we tend to open a lot of things we don't necessarily need to open. There's a lot of single-use devices that we could reprocess. So a tremendous amount of opportunity in the operating rooms for waste reduction.
Well, makes a lot of sense. And so that's for mitigation. How about adaptation?
Resilience, yeah. I haven't gotten into resilience that much, but I do think that's important, especially depending on where you live in the country.
Yeah, of course, there's some areas that are much more exposed to it. But in the end, we need to look at this as a long-term game.
Right, absolutely.
Anything finally to add that I haven't asked about?
Just that employee engagement is key because really my goal at UW Health, my goal here would be to eliminate my role, right? So that I don't have to be here and it's ingrained in every single department, every single employee that comes to IU Health. They already do it, and I don't have to engage employees. It's already sort of in their day-to-day work.
That's a great vision. Well, thank you very much for the conversation, and good luck with your journey.
Thank you.
I guess that. You were great. All right.
Yeah, Mary said afterwards, I don't like to be in camera. And I'm like, this was a wonderful interview. So I have to tell her that. So, one of the phone calls I made, predictably, after January was to call Mary and say, so how secure do you think your job is? And she surprisingly said to me, I don't worry about that. I think sustainability is a part of how IU Health wants to operate. You may have caught the remark that saving money was one of the motivations, both at University of Madison, Wisconsin, as well as here. And so I think there's arguments to be made that are should be fairly non-controversial. So I was happy to see that she was not worried about her job after 6 months after she took it. So 3 examples of projects before we wrap up with opportunities for the Institute. So as I mentioned before, the Canadian wildfire cloud was, well, a disruptive personal experience, as well as a nice scientific opportunity. You may recall that view that you see on this photo. This was at 7:30 in late July when I bicycled in. And it was when I thought the air was really bad. So I got off my bicycle. It's actually just a mile from here this way. And the sun was rising in this somewhat apocalyptic haze. And I thought by myself as I took this picture, wow, if air quality is so bad you can photograph it, then it is really bad. And that's when I kind of had the idea, okay, what does this mean to people? For me, it just smelled bad. Okay, my breathing was a little bit more labored than it usually is. But I thought about asthmatics, people with COPD, others, and I'm like, well, how many new cases of asthma did we now have because of this? And it was about a 3-4 day period that we had this kind of really decreased air quality. So we put together a research team consisting of faculty from the earth sciences. There's 2 faculty, including the division chief from pulmonary and critical care, a PhD student, actually 2 PhD students, and a postdoc at Harvard. And so we're in the middle of data analysis right now. And of course, one of the challenges here was to bring together air quality data with the health data. So the health data, of course, I understood very well. Many people in this room understand them very well. Computationally phenotyping the conditions of interest. The air quality data I had no handle on. So I learned things like all of Indiana only has 16 high quality air sensors, okay? So imagine, this is a pretty big state and we have only 16 points where we actually, these are EPA run monitors where we monitor air quality. So I'm like, okay, well, that's not going to be much helpful data because, you have 50, 100, 150 miles between some of these. Well, my earth sciences colleague said, well, no, wait, we have satellite data. So satellites also capture information about air quality, but of course at a much broader geographic resolution. But what you can do is you can interpolate the data from the ground-based sensors with the satellite data, and then put the AQI, the air quality index data, into 500 or 1,000 meter polygons. And then I'm like, okay, well then I could know what air quality a patient or a person was exposed to. So it was a great exercise in interdisciplinary team building. We are about half through with the data analysis. So hopefully in the next couple of months, I will have some real results to share. Second project, as you already may have sensed from my earlier discussion of the health consequences of climate change. Second project is about vector-borne infectious disease. So I'm working with some of the same people and some other people. There's a faculty member from geography, Dan Johnson, who is really focused on satellite data for weather and climate. And when you're a mosquito, weather matters, okay? Weather matters, habitat matters, where you are matters. And so we're going to use actually a far larger integration of data to go from satellite sensing data to predicting where mosquito populations are going to grow. And we're also going to integrate field data from the Indiana Department of Health about mosquitoes. So another fact that I learned about a year ago is that IDOH samples 200,000 to 300,000 mosquitoes every year. So what does that mean? Okay, so they catch mosquitoes in traps, Then they bring them to their lab, which is just 2 miles north of here. And then the mosquitoes get analyzed as to what kind of diseases do they carry. And so they know this mosquito has West Nile virus. This mosquito carries bird flu. And one of the most transformative statements that Lee Green, who is a senior medical entomologist for IDOH, made in our first meeting, he said, you know, I can tell from field data, sort of mosquito data that they collect, when it's likely that we'll see human cases of some of these vector-borne diseases. And so he has this graph, kind of a bar graph with the minimum infection rate of mosquitoes and human cases. And you can definitely see that those lines parallel each other. And then, of course, my thought jumped to, so how do we help the healthcare systems and people cope with this? Of course, personal protection. You can spray yourself with a pyrethrin agent that'll keep the mosquitoes off. You can also do what I did, marry a woman who mosquitoes love. Because as long as Alita sits next to me, there's no mosquitoes on me, okay? She's like my canary in the coal mine in the outdoor setting. Then, of course, you probably have seen, maybe you haven't, but the Department of Public Health sprays for mosquitoes where they are particularly prevalent. And they do that in environmentally fairly responsible fashion. There are no highly targeted insecticides for mosquitoes. So my first question was, well, how many other insects does this kill? And so Lee gave me kind of their standard operating procedures for that. Then, of course, you will get people who get infected. They show up at emergency rooms. And many of the diseases we're talking about here are fairly nonspecific. You get a viral infection, you have a fever, you don't feel good, which for the normal person isn't really that disruptive. But if you're immunocompromised, elderly, otherwise can't defend yourself against that infection very well, actually, people will die from West Nile virus and other infections. One of the remarks that Lindsay Weaver, the IDOH commissioner, made in one of her talks last year was, and some of you probably know her or her husband, Chris Weaver, who's at IU Health. So Lindsay is an ED physician. And she gave this anecdote about being the third physician who saw a patient with Lyme disease that's caused by ticks. And the 2 previous physicians had not recognized that, okay? In the very beginning, in the first infection with Lyme disease, people will not think very much of the disease. That changes once Lyme disease actually starts on late-stage complication in you. Take my word for it, and this comes from somebody who spends a lot of time outdoors, you do not want Lyme disease, okay? So monitor yourself for ticks. If you took a hike in a Indiana State Park, use protective clothing. There are ways to make sure the ticks don't attach to you, or when they attach, make sure you get them off within 24 hours. If that's not happening, make sure you get a tetracycline prescription from your clinician, because that'll kill the Borrelia spirochete. But if you wait long enough, and I know people who have long-term infection with Borrelia, it can be rather debilitating. Okay. Third and last project is a standards development project, and this is already ongoing. So this was so exciting when I heard about that. So LOINC, our effort to codify lab values and related clinical findings, they already have on their roadmap to work on environmental determinants of health. And that will be transformative because at the moment we don't have a good way of recording using structured data what was the environmental context of a patient, okay? But hopefully over the next few years we'll have context for individual or community environmental determinants of health. Think about wildfire. One of my colleagues I showed on the second slide, he's a pediatrician at Stanford, and he regularly treats people who've been exposed to wildfire, but he always puts it in the notes, okay? And yes, we can extract terms from notes and so on, but even better would be if we had codes, ICD codes, SNOMED codes that would help us characterize environmental exposure. So we have a working group that's working on this. And this morning I saw the call for presentation proposals for the LOINC conference in the fall. So I'm actually thinking of submitting this project there because it's really kind of hot these days. So last, what are the opportunities for the Regenstrief Institute? You know, this is not just a talk for Titus, so he can have another WIP talk. No, I want you to think about how could you relate to this topic. And I'm hoping to have given you some ideas, but I'll kind of summarize them. So standards development, I've just mentioned, we don't have to think about that. Health effects of environmental degradation and climate change. You know, we do a lot of research on health trajectories of people, and we definitely should engage with quantifying health effects of environmental stimuli. Let's face it, you know, Indiana in the Midwest isn't the disaster zone of climate change that other places are. You know, we're not near an ocean, so sea level rise is not going to be a problem until it is in excess of 100, 200 feet. You know, then it'll be our problem too. That probably will not happen in the near term. We don't have too many wildfires here. We do have heat waves, and we do have the weather changes. You know, you probably noticed precipitation patterns being different now than they were 5 or 10 years ago. But is it at the catastrophe level? The answer is no. However, even communities like ours need to think about how do we cope with the effects that we see here, and how can we help others cope with those. Another area, logically, from what I was saying before, is thinking about sustainability in the healthcare system. So that is actually Mary's job, and Mary and I've had a couple of talks already as to, you know, how could we do some research that helps them. And then near and dear to my heart, leveraging informatics and information technology. One example here is analytics and decision support. So every day, healthcare institutions make hundreds, if not thousands, of decisions that have sustainability implications. A physician that prescribes an asthma inhaler, okay? The choices are two: metered dose inhalers or dry powder inhalers in general. The dry powder inhalers are 30 times less, have 30 times lower impact than the metered dose inhalers on climate. But in many cases, they are equivalent. One of the reasons why MDIs, metered dose inhalers, are so much more damaging is because the propellant consists of hydrofluorocarbons. So you might have learned about those. You know, they were in most spray applications, paint, hairspray, whatnot. And the EPA actually regulates that substance, and there's actually kind of a worldwide movement to phase them out because of their climate impact. So picking a dry powder inhaler over a metered dose inhaler has a sustainability implication. And there's many, many such decisions. The last item I want to leave you with is, so I mentioned AI before, you know, and one of my colleagues, I put Jason up to this. He's currently working on a panel proposal for the EMEA Fall Symposium that I somewhat flippantly title, "Will AI kill us or will it save us?" Okay, so the kill part of this is AI's consumption of electricity is expected to grow significantly over the next decade. And the numbers are huge. You know, right now it's really small. And you're like, how can it grow so much? But it will. The second counterpoint here is So how could AI save us? Is to use AI algorithms to help us operate more sustainably, okay? So some of you are familiar with reinforcement learning, probably. So you give an AI algorithm a parameter for which to optimize. And so the algorithm, executes, makes mistakes, gets better until they eventually beat the worldwide best human player at Go or chess or whatever, okay? You can tell an AI algorithm just as well to optimize for sustainability as for many other parameters. And so I'm hoping that actually we will come down on AI solving a lot of problems for us because it can figure out how to do things more efficiently and augment human cognition and decision making in that sense. So with that, we have 8 minutes for questions or goofing off, whatever you want to do. Thank you for your attention and look forward to your questions. Not quite, but okay. We can switch it on because then the remote audience will hear you.
There we go. Okay. So in the expectation that Medicare is likely going to cut benefits for telehealth, you had in one of your middle slides that even in spite of a rapid increase in seeing patients, that telehealth had a major impact in substantially reducing carbon emissions. How do we see that impact going forward with Medicare being the largest beneficiary of that? Do we think that we'll see a rebound effect and that 8.5% from healthcare systems, and would that require then healthcare systems then to be more at the forefront in being creative and more rapidly responding to some of these more sustainable measures?
Yeah, really good question. So, the example of the relaxation of constraints on telehealth that we had during COVID and some of the benefits we have, it's actually not just climate that benefits from telehealth, it's also healthcare access, okay? Especially with rural areas in Indiana. If I can get from some remote place to converse with a clinician using telehealth, as opposed to having to drive 80 miles, I'll do that, So I think as a society, we kind of have to find our relationship to the delivery of care at a distance. Unfortunately, the waiver with Medicare expiring would, limit reimbursement for telehealth. But think about the following, Medicare is not the only payer in healthcare. So of course you have state regs on telehealth. You have reimbursement by private insurance. And so I would say, the more we can make a case for Medicare or for reimbursement for telehealth in general using multiple channels, the better it's going to be. So, life is progress and backsliding. We see that every day, every month, every year. In the end, you have to kind of keep the long-term view in mind. And yes, am I personally disappointed at the fact that climate change is vanishing from federal websites? There's an executive order that is designed to limit the EPA's authority over noxious substances such as HFCs. There's lots of stuff that's not going the right way. But there are things, people like Mary, the fact that she mentioned healthcare employees want action on climate change. We, many of us want action on climate change. There are things that actually should give us hope and that I think ultimately have the ability or the potential to bring about a much more sustainable future for us. Great question, though. Other questions?
Thanks so much. That was a really thought-provoking talk and something I don't think about very often. What fascinated me was the slide that you had that showed the Boston medical system. And there was, as they were increasing still in terms of the patients that they were serving, there was this massive drop in 2016. Can you tell us like what drove that? Because I would expect a more gradual shift, but no, it was just.
Yes, so the drop was in, it wasn't facility footprint, but I think it was the emissions profile. Well, we can actually go back to that slide. Why not? Here it is. Okay, yes, so it's the drop in carbon emissions. So I asked Bob about that because everybody was like wondering, okay, what's behind this? What they did around 2016, actually, they did a massive turnover of some of their real estate holdings, where they retired a lot of old buildings and then went into smaller facilities. The square footage of facilities, I think, is also in here. And you can see, you know, it's kind of leveling down slightly. So that is, it's basically more energy efficient buildings that happened around that time. Good eye, though. Other questions? David.
So very thought-provoking talk, so thank you for putting that all together, Titus. And one idea I was going to share and then a question. You mentioned the health impacts and that on extreme weather events and vulnerable people with chronic diseases. It seems like a kind of a proximal impact that one could address. I'm aware of a program in a research portfolio that was being developed in greater Los Angeles between UCLA and the VA to help direct homeless and homeless veterans to cooling stations and measuring the impact and how best to implement. So I think just put that in the list of ideas. You know, one thought I had, and maybe I missed it, is you're framing this in terms of climate change. You know, one could also perhaps take a route of industrial pollution and, you know, which has as an impact climate change. And, you know, of course, here in Indiana, we do have one of the lower air quality, in part due to our legacy of coal burning. And so I was just interested in how you separated that out, or why you separated it out. Did you separate it out? How do you think of these issues together?
Yeah, so the intention was not to actually separate out because the environment influences our health. You mentioned poor air quality. One of the students on the air quality project is actually a med student, and she is in Gary, Indiana. And Gary seems to be, you know, really bad in terms of industry and air quality. So even if you live next to a cement manufacturing plant, you're still going to have very bad air quality. So I probably didn't do it as well as I should have to say, we're talking about all kinds of environmental things that influence our lives, whether it's climate change or not. But I realize, you know, my talk was a lot about climate change. So to your first comment, you know, lots of projects in that area, especially with more heat waves in more places. And everybody thinks like, oh, okay, yeah, cooling centers. Okay, that's the answer. But I also want us to think a little bit more broadly, because disadvantaged communities typically don't have the tree cover that more advantaged communities have. So what does that do? That makes it a heat island in a heat wave. So meaning these areas get proportionally hotter, and we have many of those in Indianapolis. So there's lots of other considerations that would actually help us mitigate some of these effects. You know, I always think, okay, the cooling center, yes, it's a necessary thing to do, but it's, again, one of the last things we can do, you know, to help people. And so thinking a little bit from a vantage point further back actually helps us. And lots of my colleagues at the Environmental Resilience Institute in Bloomington and here, they're kind of engaged in these projects. So it's actually, I hate to use the word fun in the context of climate change, but working with these people is really fun. Last week, we were at the Indiana Resilience and Sustainability Conference in Bloomington. And when I say we, it was 3 students of mine and me, and then some other colleagues. And Gabe Filippelli, who is the co-director of the Environmental Resilience Institute, he asked one of our undergrad students, so what did you get out of this? And Ananya said, you know, the best thing was I was in a room full of people who cared and were doing something about sustainability and climate change. And she said that was so motivating. And so I thought, okay, what a great outcome of a single day that 6 months ago, she would have never been at that conference. Okay, we are at the end. Thank you very much again, and see you next time.